going to go ahead and get started. First of all, we want to thank you for joining. And a couple reminders, please check in to this session. There'll be a QR code for the check-in. You can also access a check-in code from your app. After the session, also please give us feedback on the session within the app as well. There's a rating feedback button for you to click and give feedback. So we appreciate you helping us out with that. We're going to get started. I have the privilege to be joined by great friends and colleagues in this panel break shop, and we will be talking about tracheopexy, the who, what, when, and where, and how, and many are the questions that you may have. So first, Dr. Sean Asadi, who's a surgical research fellow with us at our Esophageal and Airway Treatment Center, Boston Children's, will be talking about the introduction as to what is tracheomalacia and what do we do tracheopexy for. Hester Shi is a graduate from our program and now has been instrumental in establishing an Esophageal and Airway Treatment Center in Johns Hopkins Children's in Florida. And we'll talk a bit about the data out there as to what sort of evidence do we have about whether this works or not. Then my partner in crime and colleague, Dr. Farouk Damari, who's another surgeon in our team at Boston Children's, will be talking about the step-by-step technique and a lot of the details as to how we do it and what are the elements that go into our thought process for that. At the end, we'll reconvene for a discussion as to who should be doing this, how should we implement, how do we get started, how do we teach and train others to do this. And we want to leave some time for questions at the end, so please write them down so that we can have a lively discussion at the end. Okay, so first of all, Sean, please tell us why this is important.
Thank you so much for that introduction. We have no disclosures. So in order to talk about the tracheopexy, we need to take a step back and really talk about the fundamentals of tracheomalacia. And malacia is derived from a Greek term known as softness, but a lot of us know this more as excessive dynamic airway collapse, particularly during expiration. And so what we'll show first on the left is a bronch of a normal trachea. And what you'll see are the normal C-shaped cartilages here, and you'll see a non-widened posterior membrane. And then on the right, we'll show you an example prototypically of tracheobronchomalacia, where you're seeing that excessive dynamic collapse, particularly in the posterior membrane, and you're seeing bow-shaped anterior cartilage. And there you see the collapse. So the pathophysiology of this a lot of the time stems from, as I was saying, is the loss of the anatomical structure of those C-shaped cartilages and the widened posterior membrane. And as that posterior membrane becomes wider, you get more intrusion from the esophagus, usually leading to greater symptoms, as shown by this animation. Now, how do we diagnose this? Well, a lot of people would advocate just for a simple bronchoscopy, but we'll show you here why we would argue for a dynamic bronchoscopy. On the left, you'll see the same patient shown twice, and on the left, you'll see on initial evaluation, without doing a dynamic bronchoscopy, why you could be fooled that this patient wouldn't have tracheomalacia. You're seeing normal C-shaped cartilage and no posterior intrusion. But the moment you introduce a dynamic phase where you elicit coughing, you can then see that posterior collapse, almost 100% in this case. So how do these patients usually present? Well, we'll start with the most severe presentation, which you'll see as bruits, altes, or death spells. These are your patients that are constantly coding in the ICU. And then you're also having the patients that you're unable to extubate. They're always on some sort of positive pressure ventilation. Then you have your moderate or severe symptoms, which are those patients that are always in and out of the hospital for recurrent respiratory infections. They're having pneumonias, bronchiectasis, and they're always just coming in and out of the ICU. And then you have your mild to moderate symptoms, which are those older patients that have just some exercise or activity intolerance. You have chronic barky cough, and then your younger patients usually have some feeding difficulties or sleep disturbances. And then there is a subset of patients that are just asymptomatic. So how do we match the bronchoscopy results with their severe presentation and the treatment that we pursue? Well, if your patient has severe symptoms and they also have a severe airway evaluation, notable for tracheomalacia, then we would argue for a tracheopexy. But the moment you have discordant results, such as severe symptoms but with a normal airway evaluation, or maybe moderate or no symptoms but severe tracheobronchomalacia on airway evaluation, then we would opt for maybe some sort of medical management or trying to find an alternative explanation to why they're having those symptoms. But importantly, we want to attack this notion that has been historically thought of for tracheobronchomalacia, which is your child will grow out of it. What we have shown is that there's very little data to support that, and it's difficult to predict who does and who doesn't. So how are we going to follow these children that are constantly in and out of the hospital, in the ICU, with pneumonias? How many is too many? And so this framework of matching the symptoms with the airway evaluation, I think, gives us a solid framework of how to pursue which patients should undergo surgical treatment. And with that, I'll hand it over to my colleague.
All right, so let's get started with the case. This is a very typical example that you will see. And many of you have had this same patient. So a term boy who had a EATF repair, type C, straightforward, uncomplicated, left the hospital within a couple of weeks at most, comes back with recurrent blue spells requiring CPR, trips to the ER, CPR, the real deal, okay? You perform a bronchoscopy, and it doesn't take a rocket scientist to figure out that this child is complete collapse, very malasic, predominantly the upper trachea. There's diverticum mucosa carina, a lot of secretions. You know, the lower airway may not be that bad. So it's mostly mid to upper trachea. So what do? Well, let's get a CT, right? So I'm going to slow this down a little bit more to see the relevant structures. You have trachea, esophagus posterior to it, coming down, and then all of a sudden you see the trachea sort of faced or disappear right there. In thin cuts, you would see it better. But the radiologist reads it as effacement of the trachea at the level of the innominate artery, or innominate artery compression syndrome. This is sort of the classical description that you will find in a lot of these kids, right? So what do? Let's get to raise of hands. Who would do a tracheostomy here? This is what this child was recommended. Blue spells, severe CPR, tracheostomy. This is what he came to us for, tracheostomy. Anybody here do a tracheostomy for this? How about an anterior aortopexy? Raise your hands. I know a lot of them would. I know some of us, we did too. Okay, anterior aortopexy. How about a posterior tracheopexy up front for this? Some, okay. How about an anti-reflux procedure? There's a lot of folks who believe that bruits are a reflux event. In fact, a lot of the bruits start with the child's feeding. And so there are a lot of kids who get a fundoplication as a result of bruits. Anybody here raise their hands for anti-reflux procedure for this? Okay. Or nothing, let them grow. No? Okay. Or, I don't know, call a friend. Yeah, I would too. I would call my partners. So let's see, what did this child actually have done? So he had an anterior aortopexy, right? So preoperatively, we showed the video, anterior collapse. This is an intraoperative picture. You can clearly see the effect of the aortopexy, pulling up the trachea. Beautiful result. Everybody was happy, right? Isn't this what we all see after an aortopexy? Okay. Well, unfortunately, 2 weeks later, same symptoms. Bruit, CPR, back to the hospital. Now what? What went wrong? Let's bronch the kid again. So what do we see? Let's take a look. So exactly the same. What happened? Did the pexy stitch fall off? Maybe, but not really. So there is some effect of the aortopexy down below, a little bit of an off-center camera view, so that the carina looks better, but the area where the innominate artery was crossing is not as great. It's still collapsing. What happened? So let's get the CT, take a look. So repeat CT. We'll see there's less effacement of the trachea where the innominate artery crosses. But now you see a lot more of the esophagus. Now the esophagus has more room because you lifted everything up. Now there's more esophagus to intrude, right? And so the other thing is you see the arch. The arch is totally off of the airway. Now look how vertical this arch is. This is very typical of an aortopexy, right? So there's nothing wrong with the aortopexy. The aortopexy was perfectly done. You see the arch totally shifted off of the airway. The innominate artery is pretty much off of it. But why on a dynamic exam is there still collapse? And this is a problem as to why aortopexies often fail to produce relative and sustained improvement in these symptoms. It doesn't resolve the malacia. It does temporary improvement by affecting the ligaments that are touching the trachea and the arch, and the ligaments loosen up over time, and you still have this very malasic, wide posterior tracheal membrane, and the esophagus is still behind the airway, and that's a big issue. We'll talk about why that's another issue, particularly for kids with EA, right? So these elements that lead to the malacia and the intrusion are still there. You added a little more space for the esophagus. So you didn't really address the issue. Okay, tracheostomy. A lot of these kids get a tracheostomy, either from failure to extubate or for recurrent bruits. Well, they get a tracheostomy and they still have blue spells. Easier to manage because now you can bag them through the tracheostomy, but this is what happens. You get a tracheostomy and there's still complete collapse. Sure, you can put a longer tracheostomy, but then you run into issues of rubbing the carina and other problems that come with that. So a tracheostomy does not solve the malacia. Sure, it gives you time for the child to grow, but 2, 3, 4 years with a tracheostomy, and they still sometimes they still have malacia. So this child, after the anterior tracheopexy, fortunately did not get a tracheostomy, got a posterior tracheopexy, and had significant complete resolution of symptoms, right? Now you've addressed both issues, the malasic posterior membrane and the esophagus behind the airway, right? So Hester, tell us, what is this tracheopexy that we're talking about, please?
All right, so this animation shows us the idea of a posterior tracheopexy. You see the esophagus gets fully mobilized circumferentially and moved out of the way so that we can do airway work. And then the back wall of the posterior tracheal membrane gets pinned to the anterior longitudinal ligament of the spine with pleated sutures. Here's another view here. So you're pulling the back of the posterior tracheal membrane to the ligament on the spine. All right, so I'm going to go through some of the data in the papers that we've written regarding posterior tracheopexy and their outcomes. So the origin of the tracheopexy, interestingly, came from basically a procedure looking at recurrent TEFs and the posterior tracheopexy to rotate the esophageal and tracheal suture lines away from each other to prevent recurrence. So this paper looked at 60 patients and showed no recurrence of TEFs following repair with the posterior tracheopexy. And here's a sort of a schematic of this. So the esophageal suture line is here, and the airway suture line is then rotated towards the spine. With this, we actually found improved airway appearance and decreased malacia and respiratory symptoms. And so after this, we started doing posterior tracheopexies for more respiratory indications. So this paper looked at the experience from 2012 to 2016 at the first nearly 100 patients that underwent posterior tracheopexy for respiratory indications. So the indications ranged from the entire spectrum severity that we went through before, so cough, noisy breathing, prolonged recurrent infections, exercise intolerance, and then the more severe symptoms here, positive pressure ventilation, oxygen dependence, ventilator dependence, and blue spells and bruit events. And so nearly across the board, except for exercise intolerance, we saw significant improvements in respiratory symptoms on short-term follow-up. The median follow-up in this paper was around 5 months. This paper out of Toronto is just documenting the incidence of ALTI and bruit events in patients with EATEF, looking at around 300 patients, and found a 22% incidence of ALTI and bruit events, which is quite high. These patients got a variety of operations, either a combination of airway pexies, which were primarily aortopexies, primarily aortopexies or fundoplications, so either one or the other or both, but found recurrence of these bruit or ALTI events from 28 to 60% after these operations. This was data we presented last year at APSA, looking at our experience with tracheopexy for severe symptoms in EA patients. So from 2013 to 2021, looking at 80 patients, all with a history of esophageal atresia, mostly type C, 93%. The median age here was 6 months, and the severe indications for operation Nearly half were bruits or blue spells, 26% failure to extubate, and 21% failure to wean positive pressure ventilation. So we see here that postoperatively, we had no recurrent blue spells or bruits in this series, indicating that a posterior tracheopexy may be more effective than either aortopexies or anti-reflux procedures for this indication. And we also saw significant differences in positive pressure ventilation, ventilator dependence, and significantly more patients that were weaned to room air. In this group, this is the group of patients that are often recommended for a tracheostomy, and as we saw, that is not necessarily a fix for tracheomalacia, and we see in this study that 94% were able to avoid a tracheostomy. This paper was also presented at APSA last year, looking at the idea of primary posterior tracheopexy at the time of initial esophageal atresia repair to reduce respiratory morbidity. Oops. And we found that there were significant differences, both in hospital length of stay, blue spells within the first year of life, respiratory infections requiring hospitalization within the first year of life, need for tracheopexy within the first year of life, as well as nutrition status. So this is something that we consider at all times in the initial repair. This is the most recent publication looking at primary tracheobronchomalacia in non-esophageal atresia kids from 2013 to 2020, 73 patients, and again, similar data showing significant improvements in respiratory symptoms in this population as well. So in summary, for indications for tracheopexy, who may benefit from a tracheopexy, we've shown sort of data from these different groups. So recurrent TEF is definitely probably the strongest data. Then kids with severe life-threatening symptoms, so blue spells, bruits, inability to wean positive pressure ventilation, inability to extubate. Prophylactic at the time of initial EA-TEF repair. The primary tracheobronchomalacia population, non-EA population. And then recurrent respiratory infections, exercise intolerance. There's also, we're working on sort of papers for these, but the population of premature BPD kids with spells or high vent settings that may or may not already have a tracheostomy to either avoid tracheostomy or lower the vent settings associated with that. And then there's also the vascular ring, vascular compression population that may benefit as well. All right, so Farouk's gonna go over how to do this.
All right, I get the fun part. We talked about the who and the why. Let's talk about the how. So in this room, raise your hand if you've never done a posterior tracheopexy, please. Yes, I love it. Okay, so let's talk about how we do it. So as any other operation, the most important thing is to have a good plan and to understand the problem. So the first stage of the operation is actually what Sean already showed you, which is the three-phase dynamic tracheobronchoscopy. Now, our preference is generally to do it with a rigid ventilating bronchoscope, to do those three phases of shallow breathing, coughing to see the maximum amount of collapse that a patient may have that may correlate with the symptoms the parent is talking about, and then distension to really dilate the airway and look for other things like tracheal diverticulum or a missed or recurrent TEF, which is really important to understand. And then once you understand those things, is there a tracheal diverticulum, recurrent TEF? What about the esophagus? If the history of esophageal atresia, do an EGD, make sure it's not a stricture, it needs to be taken care of at the same time. Get a CT scan, look at the great vessels. As you know, the trachea doesn't live in isolation. It's surrounded by the great vessels. Is it compression from anomalous vessels, vascular ring, to anterior of a descending aorta that may be compressing the left mainstem bronchus? These are all things to think about when making a surgical plan. And then, of course, going to the operating room, having a team that's invested in the plan. So an anesthesiologist is comfortable with intraoperative flexible bronchoscopy, which I'm going to show you, and intraoperative recurrent laryngeal nerve monitoring, meaning keeping that child off paralysis for the bulk of the operation, which is a challenge. And then endoscopy at the end of the operation and ICG assessment to look at the esophagus. So I think there's two main safety components to this operation. With every operation we do, what are safety checks? This is a key one, okay? Continuous intraoperative flexible bronchoscopy. This is our setup. I'm sure there's different ways of doing it, but the way we generally do it is has an anesthesia swivel adapter or a peep keep and a nasal trumpet stuck through it. Basically something to give an airtight seal so you can run continuous flex bronch, as you see there in that picture, for if your anesthesiologist wants to take it easy and not hold the bronch, they can set up a little metal holder there. But the idea is that you need a guide to help you place the suture, so you know you're not hurting the airway, you're helping it. And you can see on the bottom there, even thoracoscopically, you can get this two-view where you're looking at the bronch on one camera, one screen, and then the VATS view on the other, so you can guide your stitches. The other safety thing, and I'm not going to spend too much time on this because tomorrow we have another break shop on recurrent laryngeal nerve monitoring, and Sean is presenting our data, or the data, to support this as far as reducing the rate of recurrent laryngeal nerve injury. But the routine use of intraoperative recurrent laryngeal nerve monitoring is really important because, as you can imagine, as you know, those nerves, the right and the left recurrent laryngeal nerve, are by definition at risk during this operation, especially in a reoperative field where you're remobilizing an esophagus, there's scar tissue, it's a baby, you can't see the nerves. It's a game changer for us. I mean, just last week, Ben and I did a case, and it saved our butts. You know, we're looking and, oh, that did not look like a nerve, but now we know it's a nerve, and it changed the course of the operation. So, how do you do the operation? Step by step, once you've made your plan, you got to decide. You can do neck, chest, both, right chest, left chest. Probably the simplest thing to choose between right and left chest is what size the arch is on. If it's a standard left-sided arch, you're going to go through the right chest. Open, MIS, robot, a lot of different options, which we could talk about separately, but the bottom line is you want to have a few options on the table, so we'll routinely prep patients like this. This is kind of our standard prep. We prep in the right neck, right chest, and you can see here how you can have the patient in kind of a sloppy lateral position, have that right arm prepped into the field, or even if they have an A-line there that you need, you can drape it off so it's still there so you can flip them from neck to right chest. Typically use a posterior muscle-sparing thoracotomy. It's real important to go high. Often we'll have patients who've been operated on as a newborn for EATF who have bad malacia, and the initial entry is through like the 5th or 6th interspace, which you can get away with for a type C repair. But for this, if you really want to get high on the airway to address the area of malacia, the 3rd interspace is really key because that lets you do that high thoracic outlet dissection and get up into the neck from the chest, or do a neck and chest approach. One thing I want to show you with this picture is early step of the operation. Just like a newborn type C, you're going to, well, in this case, often, if it's a reoperative, lyse adhesions for a while, get into the posterior mediastinum. If the azygos hasn't already been taken, we will typically resect the azygos, not just divide it, but resect it and use it because it's beautiful material for autologous pledget. The video you saw earlier, those pledgets, we try to avoid foreign bodies on the airway. So we'll use the azygos vein, cut it up, and make it as autologous pledget. If that's already been taken, we'll use pleura. Then full lyse of adhesions, circumferential esophageal mobilization from the whole way, all the way up into the neck, all the way down to the lower chest as far as you can go. Want to give that esophagus a gradual course into the right. Okay, we name it, rotation esophagoplasty, but really it's the same thing you're doing for a newborn, but trying to get that esophagus completely out from behind the trachea. We spend a lot of time during this for an operation, and it's super important because what you want to make sure is that you're not kinking the esophagus, especially if the esophagus is naturally leftward, especially for patients who don't have a history of EA. Because if a patient's esophagus, and it's amazing, doing this more and more, I learned that esophagus for different people in different places, sometimes leftward, sometimes middle, sometimes to the right. If you have a leftward esophagus and you're pulling it all the way to the right, you're at risk of kinking it. So that's where you want to think about doing a cervical approach as well to avoid this problem. Post-tracheopexy related esophageal stricture. So it's rare, but we do see it. We've tried to reduce that rate through certain interventions, but presents as dysphagia to solids, usually a couple of weeks after posterior tracheopexy. It looks like that in a contrast study, a little kink, bloop, bloop, from left to the right, at the thoracic inlet. Rare, usually non-EA kids who knew what it was like to swallow normally as opposed to EA children, and older children. Good news is it responds really well to balloon dilation once or twice and they're better. But we try to prevent it by doing an EGD at the end of every case to make sure there's no kinking of the esophagus, low threshold for neck dissection to give it that nice gradual course, and then avoid, key thing here is avoid rotation to the left. It can be tempting. When you have a very leftward esophagus, to just kind of push it away and leave it on the left side of the chest and then do your pexy. The risk with that is that you can pin the esophagus between your pexy or the posterior trachea and the descending aorta. And that can lead to a much more difficult problem with dysphagia than this. So, cervical approach, briefly, neck incision, just like an ECMO cannulation, retract the SCM laterally. We'll typically divide the omohyo to get a good view on things. This is a picture on the APS monitor, which you can learn more about at the recurrent laryngeal nerve session, but it gives you continuous monitoring of the nerves. Retract the IJ and carotid laterally, identify dissect out fully the recurrent laryngeal nerves. Our approach generally is not the, keep away from it, don't look at it, don't think about it. It's quite the opposite. We get right on the nerve, dissect the whole thing out like a thyroid. And then same thing with the left side. So getting around the esophagus, seeing the left nerve on the deep side and dropping it away. As you may know, the left side nerve is the one that's most commonly injured. And then stay right on the esophagus and connect all the way down to the thoracic dissection. Here's some pictures from the OR of the cervical approach. IJ, carotid, retracting those laterally, finding the recurrent laryngeal nerve. Here it is buried in a nice fat pad, and we're just going to leave it there and then dig it out, get it off the esophagus, and here we are around the esophagus with a vessel loop. So here's the key part. Okay, so we've got our exposure, neck and chest. Oh, let's go back. How do we go back? Back. There we go. Let's try it again. And forward. All right. So we have our exposure. Here we are on the chest, and you can see this is also a two-person job. One person is placing the sutures. Another is the pilot, looking at the bronch, guiding the sutures, making sure that they're placed in the midline of the trachea. Healthy bites, but not full thickness. We don't want sutures in the airway. We're generally using 5-oak-proline sutures, horizontal mattress, loaded on those autologous pledges I talked about. And then after you take those 2 bites on the midpoint of the membranous trachea, taking the bite from left to right, you see that. So this is the surgeon standing at the patient's back, so left is deep in the field. Left to right on the anterior longitudinal ligament of the spine. And doing that over and over from the carina all the way up. And you can see again, tugging on the airway, showing where those stitches are placed. So that's the key portion of the procedure. Now, a few other caveats here. One, often for children with a history of TEF, we find that they have a significant diverticulum, especially if the initial operation was done with a simple ligation and division of the TEF rather than an excision of the TEF, which is distinct and important. Because if you have a patient, who has a diverticulum and you just pexy this trachea, you're going to make the diverticulum worse because you're going to pull that diverticulum out more. So we'll generally resect that diverticulum. Here we're seeing VATS and open approaches. Here is a nice demonstration of that intramural course of that diverticulum. The same intramural course you of course can see and should see during a newborn type C repair, really getting it down into the trachea, excising it, and then doing a nice flat primary repair of the trachea before the pexy. And here's the tracheopexy again, same patient I just showed you. After the sutures are placed, pulling that membranous trachea back to the spine, this is the spine here, placing them, then doing a negative suction test, which I'll show you, which is going to be your quality control to make sure that you've helped the airway, not hurt it, that you're happy that it's staying open.
We have to build that network, right? And we invite you to participate in that if you're interested. So thank you. We're going to conclude with just these points that we can't stress enough. It is complex, but we can make a huge difference in the life of these kids. We need to turn it into a disease that was like, there's nothing we can do about it. And good luck. Talk to the pulmonologist. They'll, prescribe you some steroids, mislabel you as asthmatic, and just have terrible quality of life, to something that we can give them a significant, it's a life changer. Many of these families tell us it's like night and day, right? And so there is data to support the role. Yes, it's not randomized level 1 data, but with your help we can get there, and we'll continue to publish on it. It's very strong data if you ask me. As I said, there's not a one-size-fits-all. We really need to understand all the elements of the problem. It's not just the trachea, it's not just the malacia. Do you need to do a stricture resection at the same time? Do you need to do a stricturoplasty? Do you need to do vascular mobilization, other things, right? Team approach, and we talked about the proctor training. So we got about 10, 12 minutes for questions, and be happy to take them.
Hi, Melissa from Omaha. The question I have is, has your group transitioned to doing prophylactic tracheopexies on all of your EATEF patients? And second question, on those patients that you are doing the prophylactic tracheopexies on, are you doing bronchoscopy at the same time on those babies as well? Because sometimes they're not having symptoms yet.
Yes, and yes, and yes. So, but there's some caveats, as with everything. So it's hard to say in all patients, because if you have like a 1 kilo newborn that you're only going to do the TEF division repair and not put the esophagus together, and you may want to come back later to put that esophagus together, then we may not necessarily do a tracheopexy up front, because that may make it harder to later dig out the upper pouch. And also in a 1 kilo kid, the membrane's super, super thin, so you have to be really careful. But anything, I would say, greater than 1.5 kilos, 2 kilos, usually yes. There is a few exceptions, though. If you have a midline descending aorta, and the aorta is like right on the spine, and you don't have the experience to mobilize it or understand the arch anatomy to do it, then don't do it. You can get into a lot more trouble by doing that and you can exacerbate. It's another important point that after you tie the sutures down, look at the left mainstem bronchus, because the very anterior descending aorta, you can make the left mainstem bronchomalacia worse by then having the left mainstem bronchus going over the descending aorta. So that usually one element that we do, that we check on the scan and decide if that's going to need a descending aortopexy. Yes, they all get bronchoscopy pre-op. It's maybe not the most dynamic, but we don't necessarily know who will and who won't be malasic. We sort of assume all EA kids have some degree of malacia, particularly the type Cs. And so we just say, and the other benefit about the upfront tracheopexy, for us, it's an insurance policy against a recurrent TEF. Like, even if it's just for that, it's worth, for us, it's worth it. Peace of mind. You're never going to have a recurrent TEF with a properly done posterior tracheopexy. We still haven't had one when you do it like that.
And I'll add one thing to that, because that question, we do get asked that a fair amount. Okay, newborn type C, like, are we doing intra-op flex bronch through the ET tube? Generally, yeah, if at all possible. It's hard, and that's where having anesthesiologists, et cetera, a team who's willing to do that is really helpful. Is it possible to do a posterior tracheopexy without intra-op flex bronch? Yeah. Can you do a NUS without thoracoscopy? Yeah. Is it a good idea, especially when you're starting? No. At least that's our opinion. I mean, with experience, there are situations where you can do it, but I'd strongly recommend guiding your sutures initially when you're getting started with this.
Hi, thanks for the talk. Artie Charnagus from Providence. Sorry, 2 questions. One is, how often do you have to do the neck dissection if it's just a regular type C TF in order to do a tracheopexy? And the second question is, you mentioned using ICG to assess the trachea. How do you interpret information, and what can you do with it?
Esther, you want to take that one?
Sure.
Mike. The first question was how often the neck. So for the neck, it's been increasing exponentially as we've gained experience and comfort with it. It makes the tracheopexy many times easier, particularly for the non-EA child that has a very left-forward esophagus, or if the malacia is high at the thoracic inlet. So again, it goes along with customizing and what does the child need. If the child's malacia is predominantly at the carina, mainstem bronchi, and has already a very rightward esophagus, you may not need to go to the neck, right? If you have a kid who has malacia predominantly mid to upper trachea, very left-forward esophagus, then by all means.
I'll add, I mean, when it comes to the prophylactic pexy, if you're asking about that, for like a newborn type C, it's actually very rare that we're going in the neck, just to be
Correct.
I mean, yeah, usually the standard sort of prophylactic pexy, that we're talking about is, do the TEF excision, repair the trachea, and then usually a couple pexies just above and below that. We're not going way up into the neck for an asymptomatic prophylactic patient, generally. Is that fair?
Correct, yeah.
And then the ICG question helps us assess the perfusion of the esophagus. So you have to retract the esophagus while you're doing the airway work. Depending on how long that takes, we often want to take breaks on the esophagus so that we help with that perfusion. And at the end, once you release the traction, if there's any concern, then we'll do ICG to check that. Yeah.
You can reinforce areas of poor perfusion, particularly kids who've had prior disasters or prior bad strictures, or if there's a bad stricture already and you're trying to decide if you're going to do a stricturoplasty or stricture resection, it helps you decide a little bit on that. And so it's really more of a status check. We have had a couple delayed leaks from, we think, retraction, ischemia with delayed presentation. And so based on that, we check the esophageal perfusion status to determine, do we need to repair, imbricate, or be more cautious about this child?
Yeah, and the leaks have usually been around like a prior anastomosis.
Yeah.
So.
Jamie Robinson at Vanderbilt in Nashville. Obviously, some incredible work that you guys have done, and I was fortunate to get to train with Ben and Farouk and Hester. So just one question, and as I've moved on and I'm doing a few of these myself, as Ben knows. When you're at a center, as many of us are here in the room, where it's not as commonplace to do tracheopexies and there's not as much knowledge around it, but you see the benefits of doing a primary tracheopexy and type CEAs, which we see frequently. How, at a center where there's not as much expertise, would you encourage or guide us to try to do those as a group when we're not all doing the EA patients in those locations? Thank you.
Yeah, I think, as we discussed, I think maybe the prophylactic or newborn type C may not be the first one to start with, to be honest. Although it does seem like the intuitive one as to maybe I'm already there, let's do it. Maybe come see us do a few, we go work with you a few of the older kids so that you can understand the relationship of the direction, the vectors of how you pull the trachea to the spine. There's a lot of subtleties. For example, when we do a newborn, we place the sutures, don't tie them yet. It'll make your esophageal anastomosis harder. Do anastomosis first, leave the sutures untied, and then gradually decide how tight you want that trachea to go to the spine. So there's a lot of subtleties. That one may not be the easiest one to start with. That's just my initial bias. It wasn't the first one we started with, to be honest. And so I would sort of get more in this mentality, okay, we're going to establish a program, we're going to have this as an option, let's get the training we need, let's get the resources, and let's discuss the cases as a collaborative to see like what is a custom approach for each kid, because there's really not a one-size-fits-all.
And a custom approach for each center.
Yes.
Yeah, because that's a great question. I mean, you got to be respectful and honest about the people that you have, and you might have different great gifts at where you are that can do something special too. So,
Please.
Rusty's original article stressed looking for the anterior spinal artery. Do you still do that? And if so, how? And have you ever had any neurologic injury following these operations?
Yeah, so to that point is the artery of Adamkowitz, which is a spinal artery that fuses the spine. The theoretical risk is there that if you, as you mobilize the soft tissue off the spine, or if you do a descending aortopexy, if you divide any of those intercostals, which we don't routinely, but there is always that theoretical risk, would you affect the perfusion of the spine? We've gone as far as getting CT scans of the spine when we get the CT scan of the chest, and have mapped out artery of Adamkowitz in like hundreds of kids. And it sometimes is in the operative field technically. Knock on wood, we haven't had any neurologic complications. To the point now that we are becoming maybe more selective and not getting the CT on everybody, only if we think that it's going to involve a descending aortopexy. The problem is that sometimes you don't necessarily know that up front. There are some kids that if you see it, and particularly if the kid already had a CT elsewhere, are we going to make them repeat a CT to get the spinal artery? That's sometimes the debate. So I think it's an important piece of awareness, particularly if you're going to be moving the descending aorta and if you're going to divide intercostal vessels, that it's not a routine thing that actually we worry about that much. We worry much more about the nerves, much more about the esophagus, the thoracic duct, other things like that.
Abdullah, also from Omaha. Can you hear me okay?
We can hear you, yes.
yeah.
If you are recommending bronchoscopy for the tracheopexy, are you recommending then bronchoscopy for tying off the TEF itself every single time so that you're flush? Because sometimes you're a millimeter off or a little millimeter, the risk is that you're going to close off the trachea. So have you done that and seen that when you're tying it off, you need to do a little bit more, or you need to cut it, or you need to sew it, or you need...
Yes, we do. In fact, I like to call it a fistula excision, not a ligation, because if you ligate, you're always going to leave a stump. So if you really want to get rid of the diverticulum, you really have to open the airway. And that's scary, but if you have a plan, if you control it, if you talk with your anesthesiologist, and you prepare, then it's not a big deal. We could talk, Hester's going to talk about the taper in tracheoplasty, is how the shape, the orientation into how you excise the fistula tract, whether it's transverse or longitudinal, makes a big difference in the shape of that airway. So now we've gone to, instead of closing it transverse, excising it longitudinally, and it actually reshapes the trachea and has less of a redundant membrane. So there's ways to decrease, I guess, the incidence of malacia based on how you divide and repair the fistula.
I'll add like a practical note to that, because I mean, I could see, the expression, would you have a live bronchoscope on a newborn the whole time during the case? No, I mean, what generally it looks like is spot check. Okay, we're there, we're close, we've really cored down to it. You can see you're getting into the airway. Okay, now we're going to excise it, place our stitches, and then do another spot check with the bronchoscope, and sort of an in and out thing. The live, full case, long period of intraoral bronchoscopy obviously not going to work through a 3.0 ET tube for very long on newborn. But the general thing is to have a guide. So
Yeah, we use a 2.2 millimeter disposable bronchoscope that's amazing, has great optics, and fits through a 2.5 ET tube. So there's really no such thing as a too small ET tube. Well, maybe a size 2, but I mean, rarely do you ever encounter that. So even a 2.5, we were able to do, as we were talking about, intermittent spot check bronchoscopy for those delicate situations.
I actually think we are wrapping up on our time here, so I'd like to give a huge round of applause for all of our panelists here today. And I think this break shop was extremely successful. So if you have more questions, maybe they can hang out there for just a little bit for people to come up and ask more questions.
thank you.
Thanks.